Good morning, everyone. We're going to go ahead and get started. We have a pretty tight, full agenda, so I want to make sure we can start on time. My name is Dr. Sherry Nethersole. I'm the Executive Director for Community Health here at Boston Children's Hospital. And I would like to welcome you to this joint Community Health Grand Rounds. The Office of Government Relations and the Office of Community Health do this about twice a year. And we really felt it was important to focus on the issue of gun violence and are going to go ahead and move forward with hearing both from some experts at the hospital level, at the research level, and the community level about gun violence and where we are going. So with that, I'm going to introduce our moderator and speaker, Dr. Eric Fliegler, who's in the Children's Emergency Department here, but who has done a fair amount of research and publication on gun violence.
Thank you. Good morning, everybody. How are you? Good. Thank you all for coming today. We're really excited about this conversation. We want this to really be an interactive type of discussion. We are going to have the opportunity to have questions asked of all of our speakers, and to facilitate that, there are going to be white note cards that are distributed. Please write your question out, and then those are going to be passed back to us. So please take advantage of this. As Dr. Nethersole mentioned, this is a joint event, which is really special between the Office of Community Health and the Office of Government Affairs. Our goal here is for us all to kind of circle together and talk about gun violence. What does it mean? Who's being affected? What can we do about it? And this is kind of what we're hoping to approach today. The speakers cover a diverse set of perspectives, which I'm really excited about. Our first speaker is going to be Chynna Tyler, after I do a brief introduction about epidemiology. Representative Tyler is in the 7th Suffolk District of Massachusetts. She's a Democrat, was elected in, was it 2017 that you were elected? Is that correct? All right, great. And she's going to be giving a personal legislative perspective on this type of work. Afterwards, we're going to have Catherine Fine from the Boston Public Health Commission. She is the Director of the Division of Violence Prevention for the Boston Public Health Commission. And she's going to be talking about a wonderful program called the Boston Neighborhood Trauma Team Network. After that, we're going to have Dr. Matt Miller, who is a colleague and friend. He is an outstanding firearm researcher who has had a particular focus on firearms and suicide, which he'll discuss today. He is the co-director of Harvard's injury, let me get the proper title correct, the co-director of the Harvard Injury Control Research Center, and he's also a professor of health sciences and epidemiology at Northeastern. With that, I'm going to start talking about some of the epidemiology. Does anybody have questions before we begin? Okay. So we have no disclosures. What I have here is what I think is a really important graph for us to start to circle around this conversation today. What you have on the x-axis are the age of the population of the United States. So the youngest on the left and the oldest on the right. And what you have on the y-axis is the percentage of all deaths in the United States. And I want to point out that you'll notice that in this middle, you have a huge amount of deaths that come from violence. So this is the percentage represents all deaths, but the number you're seeing are violent deaths. The way to orient yourself, green is various types of assaults. You were stabbed. The blue, which you can see is a very dominant number there, is assaults by a firearm. So this is homicide by a firearm. And then the yellow represents self-harm or people who have committed suicide, of which a dominant number of those are from firearms. And in particular, if you look at the pediatric group, you'll see that by the age of 10 to 14, you start to see 15% of deaths are from some sort of violent means. This is, again, our young adults. And then as you go into the adolescents, 15 to 19-year-olds, you're talking upwards of 32% have violent deaths. But in total, When we look at the population of kids and young adults, 15 to 29, 1 in 5 deaths, or 20%, are from firearms alone. And the reason why I want you to keep this in mind is because you will hear, as people who represent doctors and nurses and people interested in public health, you're going to hear over and over again that this is not the realm of medicine. We should not be discussing this. And I want you to say, when 20% of young adults are dying from guns, how can you possibly tell me this is not a medical issue? So when we look back over the last 18 years, back in 1999, there were 28,874 people in the United States who died from guns. And that number used to be fairly stable for many years. But this is actually what's been happening. As recently as 2016, the number had gone up to 38,658 people dying from guns in the United States. That's a 34% increase over 18 years. If you quantify all this data and you try to understand how many people have actually died, it's over 500,000 people in the United States have died from firearms in the last 18 years. Over 50,000 pediatric firearm deaths have occurred. And even in our own state of Massachusetts, there have been 390 pediatric deaths, kids 0 to 19, who have died because of firearms. Of course, unfortunately, the distribution of deaths, there's a lot of disparities. If you are a black male in the United States, the likelihood that you are going to be killed by a gun is 15 times greater than if you are a white male. It's not quite the same when it comes to suicide. Firearm suicides are actually more predominantly white males that this occurs. Now, if I were to show the data about females, the disparity is the same in terms of the males and females who are black versus white. It's just the magnitude is smaller. But you can see that this is something that is not equally distributed throughout our country. People ask very frequently, well, how does our country compare to other countries? And it's probably not going to be a surprise to hear we have far more deaths from firearms in our country than any other of the industrialized countries in the world. Matter of fact, we are ahead of most countries who are at war when it comes to people dying from guns. When we think about who's dying, I think this is frequently where we go to. We go to the mass shootings. It's the Parklands, it's the Sandy Hooks that gets our attention and tugs at our hearts. But when you actually look at the data, the numbers are not that large. In 2016, roughly 154 people died at a mass shooting. That's where 4 people were killed or more. When it comes to unintentional deaths, and these are frequently children picking up guns and killing themselves or killing a friend, we're talking about close to 500 deaths occurred in 2016. Homicides, of course, are a huge number. We see we've got about over 14,000 people dying from homicides. And it's important to remember, this is not about gang violence necessarily. Some proportion of it is, but this is frequently domestic violence or people who know one another killing one another. But it's in suicide, where Dr. Miller is going to really focus on, that we see the majority of deaths. Matter of fact, 60% of the firearm deaths in the United States are from suicide. And the reason why this is so important is because people will say people who want to kill themselves are going to kill themselves no matter what. So I want you to ignore that data. And Dr. Miller is going to tell you why that's not the case. Overall, again, 38,658 people died in the United States from guns in 2016. So with that bit of epidemiology behind us, it's my pleasure to introduce Representative Chynna Tyler. Thank you very much.
Good morning, everyone. My name is Chynna Tyler, and I'm the state representative of the 7th Suffolk District. That's neighborhoods Roxbury, Dorchester, Fenway, and the South End. And first, I'd like to thank Children's Hospital for having me, and thank you to all the participants for being simply your interest. I'm here to provide a legislative perspective, a personal perspective about what I think on gun violence and what my role is in the legislature. And I'm honored to be in this role because I get to help shape the lens and work together as a collective with you guys to be able to combat youth violence. So I want to start by saying that as a member of the Public Health Committee in the State House, youth violence and gun violence in general is a public health epidemic. So a little bit of background about me. I'm a 5th-generation Bostonian, and growing up in Boston, I was conditioned to think that time is a natural healer of pain. However, as I became a teenager, youth violence in general have swept the floor when it came to taking the lives of people that I love most and my peers. So I just wanted to, fast forward a little bit as to today and how I feel about gun violence and my role as a state representative and as an adult. I've attended at least one funeral since I was a teenager when it comes to people that I love. And more importantly, as of today, as an adult and legislator, I say more frequently in the past 5 years, maybe about 5 or 6 funerals when it comes to youth violence in general in the city of Boston. And it's troublesome because we know that over half our students in the city of Boston live in economically disadvantaged households. So right from the beginning, over half our children are subject to barriers that impact their success and overall health. And as poverty is a direct vehicle to gun violence. So as a collective, I think we can do a better job at three things to help be able to combat youth violence. And I think the first thing is that we can work smart. And I think that we have to do a better job at working directly with the population who is impacted most by gun violence. And secondly, I think that we can spend smart. And we have to do a better job at being more frugal as to how we spend money on resources for those who are directly impacted by gun violence. And third, I think that we can provide more access. And I think that we have to do a better job at providing more direct access to resources by simply making those resources more accessible. And I'll give you an example of accessibility in my community, which I've had to deal with as a first-year freshman legislature last year. I looked at all the summer program. I was a first-year legislator, excited to gear up and attend all the summer events. However, I realized that all the summer events weren't focused around gun violence, which is, again, a public health epidemic in my community. Just last year in Roxbury, the youth violence numbers had doubled. So prior to that, at the beginning of the summer, knowing that summertime is a time where we need to be doing a lot more of this work and more focus, and I piloted an initiative to try to be able to combat youth violence because I realized that as all the resources, all the funding, just resources in general, the resources were missed in a community that has been most affected by this epidemic. And thank you for Children's for being a part of that, because you guys did come out and support me in that and just providing direct access to resources. So again, focusing on where the most need is most important here. So again, I just wanted to circle back. I know I just want to give some brief remarks, and I'm very happy to be in a room and learn from other experts here. And please feel free to reach out to me and ask me questions. And I just want to end that gun violence and trauma is a alarming public health issue. And I really want to just drive that home. This is a public health issue. And as a state representative of the neighborhood that's most impacted, I'm really committed to working on how we as a collective can work together to be able to combat these numbers. Again, these statistics are alarming and they're very disheartening statistics, if you ask me. And so again, as a fifth generation Native and as someone who cares deeply about the community and knowing that I have good partners here and doctors and Children's Hospital in general, I look forward to figuring out how we can work together to be able to diminish some of those numbers. So thank you so much. And thank you to the participants for simply your interest. Thank you.
Okay, so are my slides? Just go next slide. Sorry. Okay, there I am. All right. Thank you very much for having me. I echo Representative Tyler's sentiment and comments that thank you very much for your interest. We're really glad to be able to be here today and to talk about a partnership and an initiative that we are doing together together with a number of different partners and funders, but this is a really unique partnership and a really unique space to be in for us because the Neighborhood Trauma Team Initiative is both funded by Children's Hospital in part, and Children's Hospital is on the ground with us in the work. And Stacey Walker is going to talk a little bit more about what that looks like, but it's a unique partnership for us and in many ways a special one because we really are able to think through how to do this work in sort of a very integrated way. So the Boston Neighborhood Trauma Teams started in the summer of 2016 with really a call to action from both residents and the relatively new mayor's administration asking the Boston Public Health Commission to devise a strategy that attends to individuals in the community impacted by community gun violence and provides a set of services that attend to both trauma response, so the immediate needs following a shooting or a homicide, and the long-term services or care that families and communities need. So we started by really listening. We had initially planned 1 to 4 listening sessions in 5 neighborhoods across the city that quickly, and we plan to get it done quickly in 30 days. And the demand was really just too high. We had to listen more. So we moved that strategy from what was a 30-day strategy to a 4-month strategy. We hosted 14 listening sessions across the city and the communities of Mattapan, Dorchester, Roxbury, East Boston, and Jamaica Plain. We held these sessions in multiple languages. We did them in the evening. We provided childcare, we provided food, and we sat down with residents and we heard from them. We asked and we listened to, what do you need following a violent event in your neighborhood? What do you need in the short term, in the immediate hours after an event? What do you need in the first couple of weeks? And then what do you need in the months and years following an event in your community or multiple events that impact you or your family? So with that information, we issued an RFP, to get my sort of dates right, in the fall of, we issued 2 RFPs in the fall and winter of 2016. And what we did was we funded 5 neighborhood trauma teams, and we asked these teams to provide a scope of service that would do just that, that would be both responsive and offer a set of recovery services. So teams are made up primarily by a health center, which isn't sort of the anchor lead organization. They are required to partner with a community-based organization in their neighborhood. And they're required to were required to be able to articulate to us that together they had relationships with the community, they were able to connect with residents, and they had a broad reach, and they were required to sort of describe for us what that reach was. So in March of last year, we initiated the first 3 teams, and by June we had all 5 teams up and running. And I'll talk a little bit more about another complement we have. So the teams right now are in a part of Bowdoin, in sort of Bowdoin Greater Four Corners area of Dorchester. That's a partnership between the Bowdoin Street Health Center and the Greater Four Corners Action Coalition. They're in East Boston, which is a combination of East Boston Neighborhood Health Center, North Suffolk Mental Health, and a community group called Maverick Landing. Jamaica Plain is the interesting team that brings together 2 hospitals, 3 health centers, and a community-based organization. When I actually personally first saw this application, I was like, I'm not really sure how this is all going to come together. But Stacy will talk about the spirit of that team and what they've been able to accomplish as a pretty deep interagency collaborative. Mattapan came on later. They are partnering with a very active group called Mothers for Justice and Equality. And in Roxbury, we have the Whittier Street Health Center and Madison Park Development Corporation. We also partner with Boston Medical Center, the Louis D. Brown Peace Institute, and we are in ongoing daily communication with the police department and our Boston Center for Youth and Families. We also have a complement. So these teams work in their neighborhoods. I'll show you where they are in a moment. And their role is to mobilize after an event in their community, get connected to residents, to make sure residents know that there are resources, to really hear from residents what their needs are, and residents know how to access services, and to see if they can tailor any specific services to what residents articulate as their needs. That's sort of the community piece. And then there's a very intentional sort of activation of services to make sure that we're attending both to the family who is impacted and their immediate set of survivors. So complementary to those teams that are in 5 neighborhoods. We do need more teams. We sort of understand that there's a scale issue, and we're trying to kind of get to scale. And part of that is that we have a complementary on-call provider who provides a 24-hour hotline. They have a set of on-call responders that are available 24/7, and they provide immediate crisis response and stabilization services for any incident that happens across the city. They'll provide short-term case management, and then they will assure that individuals and families get connected to longer-term supports. So I just want to give you a sense. So this is where we are. These are the hotspots. This is a map for our planning purposes. But you can see sort of the Jamaica Plain, Roxbury, Dorchester, Mattapan and East Boston teams. And this is the work of last summer. So just to give you a sense of what they do, I only had 10 minutes. I'm sure I'm 8 minutes in. So just to give you a sense of what the volume of work was over the last summer. So these teams and the neighborhood and the mobile team provided services to about 98 events. They supported funerals, vigils, on-scene crisis support. They attended community meetings to be a compassionate presence. They facilitated coping groups and healing sessions, and about 32 incidents from the period of March to August received outreach. The other aspect to this initiative is that we have clinical teams in each of these 5 health centers that provide ongoing recovery and care. All of those clinicians are trained in evidence-based trauma treatment. Over the first 6 months, the 5 clinical teams received about 249 new clients. 63 of those clients identified as male, 63 as female, 37% as male. 79% of that group was over the age of 18. 75% identified as Black or African American, and then 45% of that group reported exposure to community violence or school violence, followed by 23% reported exposure to domestic violence and 15% exposed to child abuse. And then the last kind of comment here is one that we see consistently. It's consistent with the national data, and to me is of all of this sort of something that we really need to flag and pay a lot of attention to, is that of this cohort of 249 new clients, 74% reported chronic exposure to either a single form of violence or multiple forms of violence. And what that means is that people feel the sort of elevation of toxic stress and worry and sort of threat that people are feeling, we know has a long-term effect on health. And so we really feel like we need to pay attention to that. And as we are developing these strategies, making sure that we are, attending and trying to mitigate that longer term impact. So with that, I will introduce Dr. Matthew Miller. Sorry, I'm not going to. This is Stacy Walker, my colleague from Children's Hospital, who's going to speak much more specifically about the work of the JP team and where they are showing a lot of leadership and support. Sorry.
It's been a long week, I think. So, as Catherine said, my name is Stacy Walker, and I'm in the Office of Community Health. And if you know me, you know that I'm really operational. So, what does all of that mean for Children's Hospital and Martha Elliott? And I'm going to back up a little bit because what Catherine was saying about this particular collaboration, 2 hospitals and 3 health centers. That's a lot. I've been working with health centers for about 10 years now, and they don't collaborate very easily. And to have 3 of them within a 2-mile radius talk, coordinate, it's a big deal. So it's special. It's a special collaboration. Show of hands, how many people have been to Martha Elliott? Oh, good. I don't have to lecture anyone. So you know that Martha Elliott sits on sort of the perimeter of the 4th largest housing development in the city. Mildred C. Haley. I'm a true Bostonian, so we call it by its old name. The old Bromley Heath is what we keep referring to it. And a lot of the neighborhood trauma team work is sort of centered in Bromley Heath because there's a lot of gang violence and trauma that goes there. One of the reasons why we included Martha Elliott, because it's actually not an original member of the neighborhood trauma team, was because it makes sense. A lot of the violence impacts patients and staff at Martha Elliott, and we wanted to make sure that we had everybody at the table when it comes to dealing with families and patients and our staff. So this big team has the Brigham at the sort of table, Children's from the Office of Community Health as funders, and then we have Martha Elliott that has primary care represented, mental health, and then an operational response. So if anything happens within the neighborhood, there are shots fired every day. You should know that every day, in the middle of the day, at the end of the day, there are shots fired in the public housing development. And this is what our kids and our families are dealing with on a day-to-day basis. Also, Martha Elliott needs to know whether they need to be in a lockdown. And we didn't get that kind of information before we had this partnership. So that's quickly about the partnership, but I'm just going to give you one quick example. So last year in June, we were activated because a young person was shot at. He had a scooter. They asked him for a scooter, and he's 15, and he did not want to give up his scooter. He held on to the scooter. They shot at him. He moved his head, and the bullet grazed the top of his head. He was very lucky. He ended up going to the Faulkner and being okay, and being okay physically okay. Family-wise, they were not okay, right? We knew the mom. I worked with her in the tenant task force. We knew his sister, who attends one of our programs at Martha Elliott. We knew their friends, and it was a pretty traumatic event for all of them. And so the response of the trauma team was to work with the family, to work with the community. From our perspective, we were working with everyone. We called everyone. We called BHA, we called Rep Sanchez, because he sort of represents that district, to see what we could do to get the family out of Bromley and into another housing development. And if you know housing developments at all, you know that it's not easy to move a family. The wait list is forever to get new housing. And we were able to move the family within, I think, a month, right? And they're much happier, but we moved them out of their resources. We moved them out of their sort of family members, their resources, all of their anchors. And we had to make sure that they were in a place that they felt safe. But in the meanwhile, in that month, we had his sister sleeping on the floor in the hallway because she was afraid of bullets coming through the window and hitting her. Just the extensive trauma. So like Catherine said, we have a lot of work to do. It needs a lot of resources. We would like to have more teams. I know she was pitching for funding there for a second. And she's right. There needs to be a lot more response. But the fact that we're all working together, which is what I'm talking about, is kind of special in this way. So thank you.
Hi, everybody. Thank you for the opportunity to address you this morning. It's still morning. My name's Matt Miller, and I'm going to talk to you mostly about firearms and suicide. A question that always comes up, and Eric posed it already, is if is intent all that matters? If I'm serious enough about putting a gun to my head and pulling the trigger, won't I find another way to die if the gun isn't available? And the data I'm going to show you very quickly makes, I think, a very strong empirical case that no, you're not going to die if you don't have a gun. You may reach for something else, but it's much, much less likely to actually kill you. So in 2016, Eric went over some of these statistics. For the country as a whole, there were over 44,000, almost 45,000 suicides. More than half involved firearms. Suicide is the 10th leading cause of death in the United States, the second leading cause of death for people under 35 here in the United States, the second leading cause of death for people between the ages of 1 and 18 here in the United States. By contrast, there were about 19,000 homicides, 14,000 involving guns, 55,000 unintentional poisoning fatalities, and 38,000, 39,000 motor vehicle crashes. So there are about as many motor vehicle crashes every year as there are firearm deaths. 60+% of those firearm deaths are suicides. So you can't actually talk about suicide in the United States without talking about firearms, and you can't talk about firearms without talking about suicide. Okay. If anyone here works in an emergency department or in a primary care center, what you'll see are people who have survived suicide attempts. And you know from your experience that the vast majority of those people have taken pills. 80+% have taken pills. Another 10+% have cut themselves. You don't see the firearm attempts because they end up dead on the scene and in the morgue. So the only one you find out that 50% of all suicides in the United States involve firearms is if you work with statistics, as I do, or if you work in the morgue. Okay. I'm going to Eric went over these data. I'm just going to emphasize here that the role of firearms in mortality for young people really depends on lots of factors, whether you live in an urban or a rural area, whether you're white or black, for example. If you look in the top line of the total number of firearm deaths in the United States in 2016, if you're white, over 750 involved suicide. That's firearm suicides. 459 were firearm homicides. Now look among African Americans, 79 firearm suicides and 842 firearm homicides. It's an obscene number when you consider that African Americans make up maybe 10 or 15% of the population, and they have twice as many firearm homicides as among white people in the United States, young people. Okay, so this is a picture of the United States. When I show this to people in grand rounds at psychiatric grand rounds, for example, and I ask them what this is, they usually get that part right. It's a picture of the United States. And the sort of, I like to start off with softballs. It's variegated, and what that pattern is meant to convey is that the suicide rate, the overall suicide rate, is really different in some states compared to other states. In fact, it varies fourfold across the 50 states. That is a greater variation by a lot than any other leading cause of death. Rates of other, if you look at the other top 10 leading causes of death, nothing varies more than 20, 30% maximum, except for suicides, which vary 400% across these states. And so when I show this and I say, what do you think explains this variation? Usually what I hear is there must be more mental illness in the places where there are higher rates of suicide. Mental illness is, after all, a very strong individual level risk factor for taking one's life. The data actually don't comport with that perfectly logical explanation. When you look at rates of serious psychological distress across the 50 states, it doesn't really vary across the 50 states. These states are arrayed such that the states with the highest suicide rates are over here and the lowest are over here. Rates of major depressive disorder, rates of substance abuse, rates of anxiety disorder, rates of suicidal ideation, and rates of suicide attempts are not higher in the places where more people are actually dying by suicide than in the places where fewer people are dying by suicide. In Massachusetts, rates of mental illness are not higher than in Montana. Rates of suicidal behavior is not higher, but 4 times as many people are dying in Montana. And when I ask them, how do you explain that? Often, unless I've entitled the talk Firearms and Suicide, they don't say, well, there must be more guns in Montana than in Massachusetts. And that sort of pattern persists across the 50 states, but that's in fact the explanation. Where there are more guns, there are more people who, in a moment of vulnerability, reach for a gun and use it, and they don't get a second chance. When you reach for most other household items that are available, and you're much, much less likely to die. If you take pills, fewer than 5% of people who take pills die from that act. About 90% of people who pull a gun die. All right, so this is a very complicated slide. And what it's meant to just illustrate is that there are lots of factors that go into making somebody think about suicide and even attempt suicide. And that's necessary in order to die by suicide. But the transition from attempting to death is what determines the number of dead bodies, the number of people who die. And it's that transition, right, from attempt to death that depends more than anything else on the method that you use. And the method that you use in an attempt depends more heavily on its availability than on any other factor. Okay. So this is a pediatric grand round, so I thought I would harken back to Sesame Street episode that I remember. They didn't have dot plots in Sesame Street, but they did have this game about one of these things doesn't go with the other. It's been a while, so you know the game, right? It's sort of like that, right? Well, which one of these does, I won't sing it for you, but which one of these doesn't go with the other? Which one? This one? Yeah, that's right. So this one doesn't go with the other. The x-axis in all of these graphs is household firearm ownership rate. Massachusetts is here, Montana is here. the y-axis is the number of people who are dying by suicide that by all methods combined except guns. So when you live in high gun areas, you're not killing yourself with non-gun methods any more often than you're killing yourself than when you live in low gun areas. Okay, hi there, welcome. Now, in low gun states, people are not killing themselves by poisoning or hanging or anything else more or less than in high gun states. In high gun states, though, people are killing themselves much, much more often with guns. The net effect is that there are more overall deaths in high gun areas than in low gun areas. Okay. This slide just illustrates the same basic point. States in the Northeast, gun ownership, high to low. Non-gun suicide, I guess I need to put this up. Non-gun suicide rates are about the same. Gun suicide rates vary fourfold. Net effect, overall suicide rates vary a lot. It's not rocket science, but you see this consistently across lots of different studies. So why might reducing access to guns actually matter? There are 3 or 4 clinical observations, well-established clinical observations, that sort of undergird this idea. One is that many suicidal acts are impulsive and the crises are fleeting. The other is that, which I already mentioned, the method you use largely determines whether you live or die. And the likelihood of dying from guns is much, much higher than the likelihood of dying from almost everything else that people reach for, especially the commonly used methods like pills. And then the last observation is that if you survive a suicide attempt, you're very likely not to go on to die by suicide thereafter. Fewer than 10% of people who have survived serious suicide attempts go on to die thereafter. They have a good prognosis, even though we tend to look at people who've made attempts more fatalistically. But this is important, right? This is really important because if people just tried and tried and tried until they succeeded in killing themselves, limiting access to guns wouldn't help. But if you can prevent someone from killing themselves today by making it harder for them to reach a gun, you're more likely actually to have saved their life in the long run. Okay. It looks like my time has run out, but Eric's giving me special dispensation to go on. All right, so I'm going to skip over some slides that say there are a lot of studies you can look up that support this simple relationship, adjusting for differences in mental health characteristics in individual level studies and so on. The data that I've shown you persist. There are dozens of case control studies, maybe 20 now, that show that. Here's a study that asks the question, does the way you store a gun in a home matter? And the short of it is that having a gun in the home, no matter how it's stored, increases the risk of suicide for children. But if you store it safely, you've reduced their risk considerably. All right. I'm going to talk just for another minute or two about whether we are acting on what we already know. This is a survey that my colleague Emmy Betts and I and Kathy Barber, another colleague of mine, conducted in emergency departments among clinicians who are seeing suicidal children and adults. And we asked them, we told them, in each month in the United States, over 1,000 people die by suicide using firearms. Had a firearm not been accessible to them, how many do you think would have found another way to die by suicide? And when we put this to clinicians who are seeing patients in the emergency department with suicidal crises every day, 2 out of 3 nurses said most or all of these people would have found another way to kill themselves. Over 40% of physicians said most or all of them would have found another way to kill themselves. So it's not surprising that when you ask them what they did when they had a suicidal patient in the emergency room, that 1 out of 5 said, I don't routinely ask about guns. We're talking about people who are admitted to the ED with a suicide attempt or suicidal ideation, and only 1 out of 5 clinicians are asking routinely about guns in the home. When do they ask? They ask when the person says, yes, I have a plan and it involves a gun, but even then only 2/3 are asking. So we're not acting on what we already know. And this is reflected in the last slide that I'll show you, which is a survey that I did with a student from Northeastern, Andrew Connor, the first author on this paper, in which we did a nationally representative survey in 2015, and we asked people, did they think that a gun in the home increases the risk of suicide? Overall, only 15% of Americans said yes, a gun in the home increases the risk of suicide. And if you live in a home with a gun, you're the gun owner or the non-gun owner in the gun owning home, usually the mom, fewer than 1 in 10 people said that a gun in the home increases the risk of suicide. So there's a lot of room to move the needle, to get people to understand the risks, and I'll leave it at that. Thank you.
So thank you. I'm going to conclude by talking about legislation and firearms, but I want a reminder, there are white cards going around. Please write your questions so we can spend 10 minutes at the end having an opportunity to talk about this important topic together. So when it comes to thinking about types of legislation that can affect firearms, there are many, many different types. And the Brady Center kind of categorized them into 5 major areas. And those include how we actually sell guns, curbing firearm trafficking, so how firearm sales are recorded and trafficked. Background checks that are performed. There is a national law, the Brady Law, about background checks by people who are professional gun dealers, but there are other ways to think about this, and permits to purchase guns. Child safety laws, these are around trigger locks and the ages to purchase these guns. Bans related to assault weapons or the high capacity clips that can contain them. And then there's, of course, there are laws that are related to guns in public places. 20 years ago, in the most part, you weren't allowed to bring guns into public places around the United States. But now things like churches and schools, a lot of these laws are changing. Of course, there are other laws than that. But if you want to get a sense of looking at the United States, this is from Mike Siegel at BU. He's put together this unbelievable database that is accessible to everybody about every single firearm law in the United States going back 25 years. And this is what it looks like, a map today from 2017. You can see that California on the left in dark purple, my favorite color, and on the right, Massachusetts, 92 laws. There's a lot of laws in some of these states. And then you can see there are other states, especially what Dr. Miller was showing, especially in the Midwest and in the Rocky Mountain region, that have very, very few laws related to firearms. So the question is, do laws make a difference? And when I was putting together a talk a few years ago, my son, 12 at the time, came and showed me this article. The title was "Pro-Gun Florida Mom Accidentally Shot by 4-Year-Old Son After Leaving Loaded Weapon in Car, Bragging About Tot Gets Jacked Up for Target Practice." And the story was this woman had taken her 4-year-old son to target practice where he uses a 9mm gun, and had left that loaded gun next to him on the back seat. And he had picked it up while she was driving and accidentally shot his mom through the seat. You know, and it kind of speaks to this mentality of, like, people think that guns can be safer on young kids. And so it happens to be Florida, of all places, in 1989, actually passed a law that says if a child picks up a gun that belongs to an adult and they use that gun to hurt somebody or kill somebody, the owner of that gun can be liable. And very quickly, 11 other states passed laws, and a study was performed. And so during 16 years of study, there were close to 12,000 deaths associated with a child pulling the trigger, whether they killed themselves, they killed a friend, or they killed an adult. And this is what they found, that after laws were passed, the unintentional death rate actually went down, and it was statistically significant. So that's 0.77 represents a 23% decrease in gun fatalities from unintentional reasons. Now, you'll notice that suicide and homicides are also lower, but not statistically so. However, most of the data was pre and not post. And I think if we did this over again, we'd find that these actually worked across suicide and homicide. Interestingly, laws are not just laws, whether you can or cannot have something, but it's also about what happens if you break the law. And it turns out that in states that it was a felony, Florida, Connecticut, and California, the effect was very significant. But where the penalty was going to be a misdemeanor, it does not seem to make a difference. So some of my wonderful colleagues, Michael Monato is here today, Lois Lee, Rebecca Mannix, David Hemingway from the School of Public Health. We did a study looking at, well, what about all of the legislation that's out there? Does that have an effect on fatalities? And we looked at fatalities in the United States from 2007 to 2010. during that time, and I say these numbers because they're just so large, it's awe-inspiring in a horrible way. There were 121,084 firearm deaths during that 4-year period, 60% suicide, 40% homicide, with an overall fatality rate across the country of close to 10 per 100,000. And like Matt was pointing out earlier, it depends where you live. In Hawaii, it was 2.9. In Louisiana, it was 16 times higher at 18. And what it turns out is that the more laws you have, which is on the bottom x-axis, the lower your fatality rates. And conversely, the fewer laws you have, the more the fatality rate. And when you go and you plug in your regressions and you try to understand if we control for the demographics and everything, this is what we found. There was a 42% reduction in overall firearm-related deaths in the states that had the most laws compared to those with the least. 37% reduction when it came to firearm suicides, and a 40% reduction when it comes to homicides. This is a study, again, by Mike Siegel that looks at what about states that pass laws related to domestic violence. So basically, if you have a domestic violence order against you, there are some states that will come and actually take away the guns as a protective measure. And in states that have decided to do that type of thing, we see a 14% lower rate of firearm interpersonal homicide, and overall a 9.7% reduction. Now, of course, there are laws that go the opposite way. And in 2010, there was a law passed in Florida that was basically a gag order. It said doctors may not talk to patients about guns. The context of it was a pediatric practice that had actually, the pediatrician had kicked out a parent because they were unwilling to discuss it. And it got a lot of attention. And so this law was passed. The good news is that this law has been dismissed. The bad news is that there are other states trying to do this. And Missouri, Montana, and Minnesota all have laws that have some sort of restrictions on how doctors can talk. In Massachusetts, that's not the case. So I'm going to end with just talking about this. There are now a lot of discussion about extreme risk protection orders. These are basically laws that allow a doctor or a patient or a family member to say, my friend, my family member is at high risk, suicide or homicide. They go and petition in front of a judge. The judge decides whether those guns should be taken away. These laws currently exist in California, Connecticut, Indiana, Oregon, and Washington, and there are 19 other states, including Massachusetts, considering this. The evidence suggests, as Matt said, if you survive that suicide attempt, you will live. 90% of people will go on to live. But if you use a gun, you're probably not going to live. And in Connecticut, they estimate that for every 10 to 11 times a gun was removed, a life was saved from suicide. So 72 averted suicides. Massachusetts law is essentially the same as the others I've discussed. A family member, law enforcement, or a healthcare provider can file. The judge then can basically issue an immediate withholding of the guns that it goes up for 10 days, and then a full trial is held to make a decision about whether you're actually going to permanently remove these, permanently being up for a year, and then can be relooked at. And it looks like, as I understand, that we are highly likely to pass this in Massachusetts in the very near future. Just so you understand, Massachusetts has some of the best firearm legislation. We have legislation related to assault weapons being banned. We have large capacity feeding devices banned. The bump stocks, unfortunately so famous from Las Vegas, are banned. You need to have a license to purchase a gun in the United States, in Massachusetts. You need to apply in person. You need the police check you out. They really, really take a careful look at it in Massachusetts. And consequently, we have some of the best legislation here. Finally, the Mass Medical Society, working with Martha Healy's office, has put together information about how to talk to patients about gun safety. This is available online freely for everybody, so it kind of helps walk through as a clinician how to talk to a patient. It also has information in there that you can give to patients about gun safety. So with that, I'm going to conclude the part of the remarks that we've prepared, and now it's the time for all of you to participate. If I could invite our speakers to come on up here, and we're going to kind of go ahead and have some conversations. Thank you all for being here today. What? There's a microphone you guys can pass along. All right, I haven't had any cards passed up to me yet. Oh, we've got one card here. But this is audience participation. I'm going to really encourage you. And if you don't ask questions, I'll call on you. Okay? All right. So there's a question asked here. What does the hotline do? I think this is specific to the intervention, Catherine, you were talking about.
So,
could you use the mic? Thank you.
The hotline, and I do have some materials here, and I'm glad to share them. The hotline, you can call the hotline for any, if any resident is feeling impacted by community violence. That event could have happened yesterday near the Boston Common where we did have a shooting, or it could have happened several months ago or a year ago. They will kind of on the call do an assessment if there's a need for sort of an immediate connection, immediate sort of face-to-face connection. They'll respond within 30 minutes if there is a need. Otherwise, they'll make a plan for as soon as necessary, as soon as needed by the individual calling.
There was a very straightforward question. Will the PowerPoint slides today be made available? The answer is yes. And so just contact, who should they contact? Contact me, I'll figure it out for you. All right, next question, again for Catherine. What does short and long-term recovery mean in terms of the 249 patients that were enrolled through the trauma team network? What kind of services do they get?
Yeah. So short-term usually looks a lot like sort of stabilization. There are a lot of pressing needs that often emerge for families impacted by violence. We talked, Rep. Tyler and I, as recently as Monday, about things that come up around housing, child support, sort of support getting access or kind of doing with employment or education. So those are sort of short term, and the priority of needs will be determined by the individual or their family, sort of short term stabilization. And then there's opportunities to connect into longer term behavioral health support, which is really evidence-based trauma treatment. And those things can kind of all be interrelated, but that's typically kind of what it looks like.
So this is a question for Dr. Miller. You're going to like this one. The last slide. Does a gun in the home increase the risk of suicide, or does that mean just having a gun increases the risk of suicide or risk of completed suicide?
Okay, yeah, that's a really good question. When we speak about suicide, we're speaking about death by suicide, and when we're talking about people who have tried but have not died, we talk about suicide attempts. And so the question, as it was framed to the respondents, pertained to death by suicide, and it's sort of consistent with another question that we asked in a prior survey back in 2004, when instead of asking them about guns, we asked them whether they thought if a foolproof barrier put up on the Golden Gate Bridge, how many of the 1,600 people who have jumped to their death by the Golden Gate Bridge would have found another equally lethal way to take their own lives. And in that survey, 1 out of 3 Americans said not a single life would have been saved by putting up a foolproof barrier on the Golden Gate Bridge. Another 40% said most or all would have died. So there is a certain fatalism associated with the way people view suicide, or at least the way they view the feasibility and the utility of restricting access to highly lethal methods.
Matt, could you speak to the data about what happened in Sri Lanka and in England that you had to kind of slide through real quick?
Sure. So Eric is asking, are there examples of places where access to a highly lethal and commonly used method were reduced, and what happened to the rates at which people died by suicide? I've showed you relationships and case control studies and talked about ecologic data, but I haven't told you about any natural experiment. And in Sri Lanka, for example, where after the agricultural revolution, the prosperity of the country increased, but attendant with that, so did the number of people who were dying by suicide. Because in Sri Lanka, as opposed to the United States, the vast majority of suicides involve highly toxic pesticides, as they do in many developing countries, including China. So with the Green Revolution, as highly toxic pesticides were used more and more frequently, the rate of suicide in Sri Lanka went up, so that Sri Lanka had one of the 2 or 3 highest suicide rates in the world. Thanks to some really great work by epidemiologists like Michael Edelson and David Cannell, they convinced the Sri Lankan government to successively ban some of the most toxic WHO pesticides in that country. And coincident with the ban of those pesticides and the decrease of those pesticides in use and the replacement with less toxic pesticides, the rate of suicide declined by 50%, all of which was driven by a decline in the rate of pesticide suicide. Rates of suicide due to other methods didn't go up and they didn't go down. So the net effect was a 50% decline in suicides in Sri Lanka without a change in the rates at which people were attempting suicide. They just were attempting with less toxic pesticides.
Thank you very much. This is for Representative Tyler. How are you supporting the Extreme Risk Protection Order bill?
So we just passed that bill like recently, the EPRO bill. So I signed on to it, and I'm supporting Representative Decker, who is the lead sponsor in that bill, and whatever we can do to push that. I think as far as what I'm personally doing to support legislation in general is just making sure that the State House and my colleagues in the State House are aware of these matters. So, and that's very difficult to do. You have a lot of people with a lot of different perspectives in there, coming from different avenues. So just one, awareness, and two, supporting legislation that's already out there. And then as I move up in the legislature, again, I'm a first year freshman, figuring out where I can exactly insert myself to be able to further support additional legislation like EPRO.
Thank you. So this is for the group. With community or gang violence, what is the source of the guns, given that Massachusetts has strict gun ownership laws, and what are our opportunities to intervene?
So the source of the gun, meaning like where are they coming from? So that's actually being studied right now with the AG's office, actually where are these guns coming from? So I'm actually working with their office to figure out exactly, where are guns coming from? As you mentioned, enhancing our data system as far as tracking that information. So that's something that I'm definitely interested in working on and have been, beginning conversations. And what can I do in the community is the second part. What's the second question? Sorry,
The second part is what can we do about it?
What can we do
I think
about
you
it?
kind of just answered that.
Yeah. So just, more work to be done on that. But again, that's an ever-going initiative. So wherever you can support, feel free.
Great. Do you want to say something before I ask the next question? Okay.
Actually, I do want to say one thing.
Please.
In asking the question, sort of, where do the guns come from? The other piece to that is why are young people or people in our communities feeling that they need to carry a gun? I mean, that is, we have data that came from a study commissioned by Children's Hospital that parents across the city of Boston 26% feel like their neighborhood is unsafe. In the communities that we've got neighborhood trauma teams, that range is between 20 and 37% in parts of Roxbury and Dorchester. And so the question of, if you feel unsafe, is there the compelling reason to protect yourself? And so I think in thinking about legislation, it's really also going back and listening to young people and people who feel the need to carry a gun and sort of what that all means. I don't have the answer to that, but I think it's an important question that we need to ask.
Thanks. And apropos of the source of the gun, it also depends what firearm death you're talking about. If you're talking about suicide, the vast majority of those guns come from people's homes. They've been there for a long time, and for the most part, they've been acquired legally by the gun owner, and he or his member of his family uses that gun. If you're talking about women who are killed, often it's also a gun that has been in the home. Interpartner violence, if you look at where people are dying, very often when children, old people, or women are killed, they're killed in their home with a gun that has been in that home for a while. When you're talking about interpersonal violence, especially in the inner city, where people are dying more on the street than in their home, those guns eventually came from somebody's home. Lots of guns through theft or diversion, but the kinds of approaches to reducing violence depends on sort of the source of the gun. The same sort of legislation that you think might inhibit the transfer of guns across state lines that are used to kill young men in the inner city are not the same sort of approaches, legislative or otherwise, that are going to reduce the likelihood of the gun in someone's home is going to be used to kill someone in that home, either through intimate partner violence or suicide.
Can I just make one more comment around what can we do about it? So I just want to talk around preventative measures. So as you can see, we have MDs here, experts here on the panel. It's very, very, very difficult to solve this issue around gun violence. However, I think if we focus a little bit more on preventative measures, when you're 7 years old and you first have that thought to be able to pick up a gun, what can we do to be able to divert you from thinking about that and put you into extracurricular activity or whatever we can do to kind of steer you from that. So I think, again, in our schools and different entities that, our children are circling, what can we do to make sure that our programs, that what we're offering is strong so that they won't even think to pick up a gun and kill themselves or kill someone else or what have you.
So we've run out of time. There are more questions we can get to. It just speaks to what a wonderful audience you all have been today. I want to give a very special thanks to our speakers. This has been a wonderful conversation. Thank you guys for coming today. Thank you all very much. Take care.
So was it like very kind of like, was this like child focused? Because you found it a different conversation than like